You're listening to This Week in Cardiology from theheart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.
You can now access the latest in medical news on your Amazon Alexa-enabled device. Join me, Perry Wilson, every weekday morning for Medscape Medical Minute, where I highlight the top medical stories of the day. To add Medscape Medical Minute to your flash briefing, search for Medscape Medical Minute on Amazon and click Enable. Or open the Amazon Alexa app, go to Skills, search for Medscape Medical Minute, and click Enable. Then say, Alexa, what's the news? Or, Alexa, what's my flash briefing? I hope you'll join us.
Hi, everyone. This is John Mandrola from theheart.org, Medscape Cardiology, and this is This Week in Cardiology for March 24th, 2023. This week, exercise, sudden cardiac death in sports, new TAVI data, behavioral psychology, the electronic health record doing good things, maybe, and coffee. First study is about fitness and longevity. Now, this podcast has long promoted the benefits of exercise. Any exercise is good, but exercise that increases fitness is probably better. My level of evidence for this is not based on trials. It could never be based on trials, right? Because how can you randomize people to being sedentary? So, in this case, we have to rely on observational studies. But the problem with these kinds of studies is confounding and bias. Jack has published a beautiful example of this. The author studied veterans who had multiple exercise tests over the past 20 years. Now, this included about 93,000, mostly males. They assessed exercise tolerance at baseline and then follow-up and assigned individuals to quintiles based on their age-predicted fitness. Then they followed these people for 6 years. Cardiorespiratory fitness increased by at least 1 MET in approximately 29% of the people and decreased in approximately 46% of participants. And the main results were that an increase in fitness of approximately 1 MET from the initial evaluation was associated with a progressively lower mortality risk regardless of the fitness status at baseline. So simply stated, gaining fitness associated with better survival no matter the baseline level of fitness. And a decrease in fitness was associated with a progressive increase in mortality risk, except those who had high baseline fitness. So the authors concluded, quote, these findings strengthen previous reports from comparatively smaller studies assessing sequential fitness by a standardized exercise tolerance test and by a recent large study using self-reported fitness measurements. My comments. Okay, I love exercise. Likely you do too. I tell my patients that daily exercise is like a super drug. It helps the mind, the body, and if there's a soul, it helps that too. But when I wear my stop and think science hat, I am not sure about these kinds of studies. It's tempting to think, as the authors urge us to, that the structural and functional physiologic changes resulting from aerobic activities render an individual more resistant to injury or disease, and that ultimately results in lower mortality rates independent of any genetic factors. Okay, maybe. Instead, I see this kind of study as a shining example of bias. No matter the statistical adjustments, bias in that people who gain fitness are extremely likely to have other factors that lead to longer life. And conversely, those individuals that lose fitness surely have other factors that cause lower survival. Also, this could easily be reverse causation in that healthier people gain fitness while unhealthier people lose fitness. So, as it is with coffee and blueberry and quinoa and saunas, the scientific enterprise, I think, could save resources by not doing these sorts of studies. Exercise, I think, could be put in the no smoking category. We don't do studies on the risks of smoking and benefits of quitting smoking because it's not needed. Exercise can go in that category. Health-wise, normal, daily exercise seems like a parachute. Next topic is sudden cardiac death in sports, and this one has a twist. Jack has published a very nice observational study from a European consortium of 3 registries of athletes, France, Netherlands, and Sweden. The investigators, first author Oriane Weissman, sought to assess the incidence, characteristics, and outcomes of women presenting with sports-related sudden death. Now, these findings are surely going to inform screening policies, which I think is important. So over a decade, these registries had about 34,000 episodes of sudden death, and 760 of them, or 2.2%, related to sport, but this included only 54 women of 34,000. The incidence of sports-related sudden cardiac arrest in women was 0.19 per million. In men, it was 2.63 per million. That's more than a 13x higher rate in men for sports-related cardiac arrest. So the authors concluded, quote, these findings emphasize the dramatically lower risk of sports-related sudden cardiac arrest in women compared with men. Despite similar subject characteristics, this should be considered in designing pre-participation screening strategies in the future. Okay, my comments. Professor Ann Curtis is the first author of a very nice accompanying editorial. I would read it. It's worth a read. She and her co-author make the point that in overall populations, like regular populations, women have a lower risk of sudden death. So these findings with sports-related cardiac arrest parallel those findings. Interesting also is that in the risk of sudden cardiac death seems to increase with age in men, but not in women. Now, another perhaps tangentially related, sex-related difference in sports cardiology is that women athletes seem not to have the increased risk of AFib with higher levels of exercise that men do. Adrian Elliott has a nice paper in the European Heart Journal 2020, and I'll link to it, in which they looked at the UK Biobank and found that the association between physical activity and AFib declined in females up to 5,000 METs per minute per week, whereas there was a clear signal from theirs and other studies that higher levels of exercise in males associates with higher AF risk. This makes me think that there must be reasons for these sex-related differences in the arrhythmia risk from sport. Things like differences in substrate or atherosclerosis or ischemia or plaque rupture or even maybe the protective effect of estrogens. But I would not spend too much time on why this is. I think this study, as well as many others that are cited in this paper and editorial, confirm that there is a lower risk of sports-related sudden cardiac arrest in women, and I think that is a good thing to know. And the two main conclusions I would make is that we should absolutely promote exercise in both women and men, and crucially, since the net benefits of pre-participation screening is extremely dubious in men, I have argued against it many times over. Given this 13x lower rate of sudden cardiac arrest in women, we surely should not recommend pre-participation screening in women. It's useful here to always remember those 2x2 contingency tables we learned in medical school. When you're dealing with a very low incidence condition such as sudden cardiac arrest in women athletes, the vast majority of positive screening tests would be false positives, which in this case would be a terrible thing to do because you would then be giving a healthy person a medical disease that they don't have. Okay, third topic is the EVOLUT trial 3-year data. ACC brought news about TAVI versus surgical aortic valve or TAVR, specifically the 3-year results of the EVOLUT trial in low surgical risk patients with severe aortic stenosis was presented. And I've discussed TAVI versus TAVR many times over, and one of the main concerns is long-term outcomes. And that's why it's good to have 3-year results. The registry data now shows that TAVI has surpassed surgical aortic valve replacements for AS. And that's sort of understandable, right? Because if you can get the same results with TAVI, patients will obviously favor the less invasive procedure. And it doesn't hurt that cardiologists control the patients, and we do love our procedures. So in high-risk patients, I have no argument. There's no argument. TAVI is great. But I've long worried that acceptance of TAVI in lower-risk patients may have outstretched its evidence. Now, the teaser here is that the EVOLUT data was really quite encouraging for TAVI. But before I tell you the 3 results, let's briefly do some basics. Okay, there are 2 types of TAVI, balloon expandable and self-expandable. One of my colleagues favors the former, another colleague favors the latter, but of course anatomy plays into that decision as well. The EVOLUT trial studied the self-expanders. It measures death and stroke as primary endpoints. Good, these are good endpoints. Now, other differences in the two procedures, TAVI versus TAVR, include the time of recovery, of course, perivalvular AI, hemodynamics, that is how well the valve opens, ease of coronary access. For instance, to do a coronary angiogram after a self-expander requires putting the guiding catheter through a cage before getting into the coronaries. Then there's the issue of leaflet thrombosis and structural deterioration of the leaflets over time. And of course, one that affects my world, heart block and the need for permanent pacing. Okay, now let's do the original EVOLUT trial. The original EVOLUT trial was about 1,400 low-risk patients with AS randomized to TAVI or TAVR. The mean age was 74. This was a non-inferiority trial. Now, the results, which were published in New England Journal of Medicine, and I'll link to it, were difficult to interpret because they analyzed 2-year data when half the patients had reached 1-year follow-up. Now, I know that sounds weird, right? So at 24 months follow-up, data was available for only 72 patients in the TAVR group and 65 patients in the surgery group. That's only about 10% of patients in each group, which is weird that this was in New England Journal. Stroke or death occurred in 5.3% of TAVI, 6.7% of TAVR. That 1.4% absolute risk reduction was good enough for a more than 99% chance of non-inferiority. But again, it was hard to make much of these Kaplan-Meier curves because so few patients had been followed for 2 years. Okay, now at ACC and of course in JACC, there's the 3-year data, which looked reassuring. Here's the results for the primary endpoint. TAVI held a 2% absolute risk reduction at 2 years and a 2.9% absolute risk reduction at 3 years. So you can close your eyes and you can imagine the 1-year Kaplan-Meier curves, then they just continue the same separation at 2 and 3 years. Now this is really good for TAVI proponents because in the balloon expander trials, specifically the 2-year results of PARTNER 3 low-risk patients, the stroke death curves come together at 2 years. Okay, now this important secondary outcomes that I mentioned above. In EVOLUT, at 3 years, TAVI held an edge for hemodynamics. That is, better opening, smaller gradients with TAVI. Mild AI, aortic regurgitation, was much more common with TAVI, but moderate to severe AI did not differ at 3 years. But pacemaker placement was also much higher in the TAVI arm, 23% versus 9% TAVI versus TAVR. Okay, my comments. This primary endpoint data is quite reassuring, but low-risk patients who are 74 years old have a far greater timeline than 3 years. I mean, 74 is like the new 64. And there's many unknowns that remain, such as valve longevity. How much does the higher rate of AI and pacers pull on long-term outcomes with TAVI? Now, I've come to love pacemakers because pacemakers are pure medicine, as in sick patients need our help and pacers make them better immediately. But avoiding heart block and permanent pacers is a huge advantage for surgical aortic valve replacement. You don't want a permanent device in your heart unless it's necessary. Now, also, I have to say, covering access to the coronaries also seems like a big deal. My interventional colleagues say, John, it's mostly easy to engage the coronaries through these things, but sometimes it's not. Okay, and if you're having a STEMI and it's not, then that doesn't seem like a little thing. Bottom line is, we have to be totally transparent with patients about the uncertainties beyond 3 years. In a perfect world, patients would get the benefit of a totally neutral heart team advice. Do we live in such a perfect world? I'm asking. All right, next topic is the issue of nudging and behavioral psychology. I want to mention 2 studies at ACC that looked at nudging as a way to improve medical quality. The first trial looked at improving flu vaccination. In the nudge flu trial, Danish investigators studied the effects of nine different types of nudging letters sent to Danish citizens. They excluded about 20% of citizens. Nearly 1 million people were randomized to these different types of letters. Now, if you're into behavioral psychology, like I am, of the Tversky and Kahneman type, you're going to love the study methods. But first, some background. Recall that the IAMI trial found that flu vaccine given shortly after MI led to lower rates of MACE at 1 year. And the DanFlu-1 trial reported at ESC last year found that elderly adults who received a high-dose quadrivalent influenza vaccine compared with a standard dose saw a significantly reduced risk of death and hospitalization for influenza or pneumonia. So there can be debate as to the benefits of flu vaccine in healthy young people, but the evidence in older adults, especially those with heart disease, surely favors flu vaccine as a benefit, and the nudge flu trial enrolled older adults. Good. So now to the psychology of these letters, which was great. It's so cool. There was a standard informational letter, kind of the control group. Then there were letters with gain framing, letters with loss framing, letters with collective goal framing, letters that had an expert authority type framing, and letters with cardiovascular gain framing. For instance, in the cardiovascular gain letter, quote, in addition to its protection against influenza infection, flu vaccine also seems to protect against cardiovascular disease such as heart attacks and heart failure. The primary endpoint of nudge flu was receipt of influenza vaccine on or before January 1st, 2023. The main results were depicted in sort of a forest plot like you see in meta-analyses, and the standout was the cardiovascular benefit framing letter. Most others hovered around the null line of no effect. But here's the thing, though, the numbers. Compared with usual care, influenza vaccination rates were higher in the group receiving the E letter that highlighted potential cardiovascular benefits, but the actual numbers were this: 81.00% versus 80.12%, a difference of 0.89%. And that had a p-value of less than 0.0001. Now, highly statistically significant results, so we'll talk about that. With my comments, I love this trial design. They studied different framing of words in an RCT design. My favorite framing question is this. Before cardioversions in patients who take DOACs, we used to ask patients, have you taken all of your anticoagulant meds? And very few answered no, and we did a lot of cardioversions. But then we changed the question. Quote, in the last 3 weeks, how many doses of the anticoagulant have you missed? Now we postponed a lot of cardioversions, and I wish we were smart enough to do an RCT of this different framing of the question. The point is that the arrangement of words matters a lot. Now, another teaching point from this trial is the notion of how a tiny difference, less than 1 percentage point, can have a super tiny p-value. This is a statistically robust finding, no doubt, but I struggle to understand how the difference between 81% vaccinated versus 80.12% vaccinated is clinically significant. And big numbers in studies can lead to tiny values for very small absolute risk reductions. Now, you can imagine that Denmark is probably a tough country to show benefits of nudging because so many of the citizens are already vaccinated. Maybe if you tried this in a place with lower vaccination rates, you might get different results. Lancet published this paper. It's a brilliant paper, and it's worth a read. Okay, another nudging type trial at ACC is called the Better Care HF trial. Now, Jack has published this pragmatic cluster randomized trial from authors at NYU, and they were comparing the effectiveness of two electronic health record EHR embedded tools versus usual care in the prescribing of mineralocorticoid receptor antagonist, or MRAs, in patients who had heart failure with reduced ejection fraction. I like this trial for many reasons. First is that I liken spironolactone as a secret weapon. It shouldn't be a secret weapon because little old spironolactone has some of the strongest data there is in heart failure. For instance, go back and look at the Rouse trial, 1999. This was an RCT of patients with heart failure with reduced EF, and that little inexpensive MRA reduced mortality, not heart failure hospitalizations, by a whopping 11% in absolute terms. 11%. Now, the second reason I like this trial is that the electronic health record is overwrought with alerts. And before, anyone adds another one, it should be studied empirically. Good intentions are not enough when it comes to distracting doctors. And the cluster randomization here involved the cardiologist, and one alert came up during individual patient visits in the right-hand column of the EHR, and it had important info on the patient, systolic blood pressure, EF, eGFR, and potassium. Another EHR tool was a monthly automated message that was sent to cardiologists, and it linked a list of patients who met MRA eligibility, and the third arm was usual care. And what they found is that both of these electronic tools worked. New MRA prescribing occurred in 30% of patients in the individual alert arm, 16% in the message arm, and 12% in the control arm, and these were all statistically significant. So my comments, I think we underprescribe MRAs, and we surely understudy policy interventions. So good on the investigators. I guess I would add one word of caution. Now, the absolute number of prescriptions is an endpoint, but it is still a surrogate endpoint. A better but harder trial would be to see if the patients in the electronic alert categories have better outcomes, like hospitalizations or adverse effects, etc. And I say that because prescribing MRAs requires labor and attention to detail. You have to check potassium, watch for drug interactions, and while the drug performed amazing in a trial environment, real-world use might be different. Okay, final short topic. New England Journal of Medicine has published a coffee study. Another coffee study. This was a crossover RCT looking at the acute effects of caffeinated coffee consumption. It was led by Dr. Greg Marcus at UCSF, and they've done a lot of work in this space, especially like the alcohol space. They had 100 volunteers who were very special volunteers. These volunteers were willing to abstain from coffee for at least 2 straight days. And they were recruited, they were fitted with ECG monitors, step counters, wrist monitors, etc. And the individuals were randomly assigned to consume coffee or to avoid coffee for 2-day periods. And the primary endpoint was the number of premature atrial contractions. And, thank goodness, they found no significant difference, 58 versus 53. Now, they report that PVCs were higher on the coffee days, but the absolute numbers tell a different story. It was 154 PVCs versus 102 PVCs, and given that humans have 100,000 heartbeats per day, this is like 0.15 versus 0.10% PVC burden. It's totally not clinically significant. Caffeine consumption days associated with 30 minutes less sleep. But again, wrist-worn sleep monitors aren't super accurate, and this was a secondary endpoint, and so who knows what that means. My comments. Okay, caffeine is a drug. When it's delivered in coffee, it's extremely pleasant. When it's delivered in energy drinks, probably not so much. And I would also remind everybody that toxicity of anything, even water, turns on dosage. We put huge burdens on patients with AFib, for instance. We ask patients to lose weight, exercise, attend to their sleep, reduce or stop drinking alcohol. What I take from this study, along with the mountain of reassuring observational data with coffee, is that patients can have their coffee. That is, if it does not affect them individually. And I'll say this again, I really don't think we need more studies of coffee. We can study sleep, yes. Alcohol, yes. We even study yoga. But I'm satisfied with our knowledge base of coffee, which seems like one of life's safest pleasures. Okay, that's it for this week in cardiology. As always, I am grateful that you listened. Thank you. And remember, if you like this podcast, please consider taking the time. Just give us a rating, write us a 1 or 2 sentence review, make a comment on the website. These things go a long way to helping others find us. Until next week, this is John Mandrola from the Heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the Heart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.